Okay, good afternoon, everybody, and welcome to the Hackney Health and Wellbeing Board on a much cooler afternoon. So hopefully everyone's not sweltering too much, either at home or in person. Great, I think we're going to make a start. So really just welcoming actually, I'm just going to wait a sec. So we've got a couple of people just joining us in the chambers. Okay, so just a few bits of housekeeping. So we do have a hybrid meeting and we've got some people who are going to be here in person presenting. And we've also got some people here in the chambers as well as people online. So just for the people online, please do just pop your hand up in the normal way. For the people in the chambers, please do give me a wave because sometimes I don't always see. So please just make sure that you get my attention. A few other bits of housekeeping that I think we're all pretty proficient at these days. Just please mute yourself if you are online unless you're speaking. Okay, and if you've got any IT issues or any problems from a kind of technical perspective, do pop these in the chat. And then we'll get going. So just for noting, we have some presenters who are going to be presenting in person, Danny Turnton, Freaks Kaminga and Sadie King. And we also have some guests here in person who I think, although no, Tony, you're now online. So we've got Tony Wong, CEO of HCVS, joining us. Yeah, Danny's here.
Oh, thank you.
Yeah.
He's here.
Okay, so far so good. Right. Okay, so a few bits about the membership of the board. I think just first of all noting that Mayor Glanville has now stepped down from co-chairing the board, and I just really wanted to formally thank the Mayor for all his energy and enthusiasm that he has injected and his drive and direction into the Health and Wellbeing Board, and really just to publicly acknowledge and give him many thanks. And we really look forward to continuing to work with him through his role as the Mayor and the Health and Wellbeing Board. So I'm delighted to welcome Councillor Kennedy, who's going to be taking up the role of co-chair with me, and I'm really looking forward to working with you, Councillor Kennedy, and again, all your drive, passion, encouragement and energy for health and care across Hackney. So welcome in a different role to the Health and Wellbeing Board.
Thank you very much.
Just noting a few other appointments across the partnership. So we have a new GP Confederation CEO, Andreas Lambriano. So welcome to Andreas. I can't see him on the meeting today, but a big welcome to him. Just noting that Susan Masters has left HCVS and will be replaced by Jess Lubin, but Jess has sent her apologies today. But again, we look forward to working with Jess going forwards. We wanted to, subject to being quorate, we wanted to appoint the following new members to the Health and Wellbeing Board, and really just more of a formal. Oh, Sandra, yep.
Just not. Oh no, it's not. Sorry about that. I just wanted to remind you that Raj is going to be standing down after this. Okay.
Thank you for the reminder, but yeah, we have got some more thanks coming. Okay, then, so just a formal appointment to the new members of the Health and Wellbeing Board. So this is more of a Nina Griffith, who is the Director of Delivery in the City and Hackney Place-Based Partnership. Whilst Nina has been a member of the board under a different title, actually it's just really a formally acknowledging the appointment of her in her role as working with the ICS, but just really recognising that Nina's role is very much the Director of Delivery in the City and Hackney Place-Based Partnership, but she is obviously part of the ICS team. Okay, and then the last thanks that I wanted to give is to Raj Radia, just to say a huge thank you to Raj for all your work through the LPC and the community pharmacist. Really just to thank you very much for your sort of never-ending and untiring commitment to really supporting the community pharmacists, residents and patients, and on a personal note, just have been a real pleasure to work with over the years, so thank you very much.
I'd like to
Health and Wellbeing Board for having me on board as a community pharmacist. I hope my successors will play an important role. I've been working community pharmacist in my place for almost 36 years. So I've got a lot of experience and knowledge. I think it's time to step down because obviously it's a new committee and I've decided not to go forward with it, but I'm still around for a short period of time. And yeah. Thank you very much for the support you've given us as well. I hope I've given the same to the public I serve as well. Yeah.
Yes, definitely. Okay, so just double checking in terms of choracy to appoint the new member. Nina. Yep, we are correct. Okay, so that's all good. Okay, moving on now to apologies for absence. We've got a fairly long list of apologies, which I'll just go through in turn. Detective Chief Superintendent James Conway, who I understand is being represented by Superintendent Dale Speed. Yep. Councillor Fajana Thomas, Mayor Glanville, Nina Griffith, Stephen Hayes, Rosemary Jawara, James O'Neill, Paul Senior, Kathleen Wellerdon, Mary Clark, and Councillor Williams. Louise Ashley is being represented by Bazrat Sadiq, Deputy Chief Exec of Homerton Healthcare. So welcome, Baz, to the Health and Wellbeing Board. And then we have some people joining online. I've got Francis Haste. So thank you very much for letting us know, Francis. Okay. Now moving on to declarations of interests. Anything that anybody wants to declare before we move on with the meeting, recognising the agenda items? Okay, good. So the next agenda item is the draft minutes from the meeting we had on Thursday, the 8th of March, and really just asking board members to approve the minutes, checking that they're correct and whether they're happy to sign off the minutes as an accurate reflection of the meeting. Yes. Yes, okay, good. So moving on now to the action tracker. So we have 2 items on the action tracker. Which both relate to the Hackney Council's Eliminating Violence Against Women and Girls strategy, one of which has been completed, the first one, and then the second one was just really around following up, Cathal following up with public health pharmacies, public health colleagues regarding pharmacies, and I guess working with Raj. I don't know if that has been completed or not.
Which one is this?
So this is the second item on the action tracker.
I can't get my agenda out. So
Oh, it's fine. It's to map recognition and response to domestic abuse within community pharmacies.
Message to, sorry, what?
Do the mapping and recognition and response around domestic abuse. It was around working with community pharmacy. It may, if it's not it may be.
No, I think somebody did sort of email me. I didn't get a chance to reply back to them, but I'll try and see if I can. Great. I think the message was when I think the code word is Annie when they walk into a pharmacy. I think sexually abused or the abuse generally, and it was a safe place for them to come in there. I'll try and pick up with them. I meant to do that. Yeah, thank you.
Great, thank you. And I think one of the discussions we had ahead of the Health and Wellbeing Board today was just around the action tracker and thinking as we go forwards about how we make sure that items on the action tracker are ones that are relevant to the Health and Wellbeing Board as a whole to kind of take forwards. I think there will be actions that we'll need to follow after Health and Wellbeing Board meetings that may relate particularly to one partner working with another partner on something quite specific. And that's good. It's good that the Health and Wellbeing Board are identifying those, but actually we want to keep the action tracker to real sort of key coordinating and strategic actions which the Health and Wellbeing Board need to be taking forwards. So the plan is that the action tracker will reflect that going forwards. So I'm going to suggest that we complete the second action on the action tracker today in light of that. Okay. Yeah, please come in, Chris.
May I return just to agenda item 1 because we have got updated terms of reference.
I think they're very good terms of reference. They do reflect many of the new duties, but there is one duty that I think is still missing, which is an interesting one, which is in relation to receiving the, let me get the exact wording, joint capital resource use plans, and it states in the guidance that there is a new duty for the NHS trusts and foundations trust to share their joint capital resource use plans and any revisions with each relevant health and wellbeing board. So in the times of particular financial stress, it's an interesting one that has now been written into the guidance. So we may want to reflect that in the terms of reference as well.
So just recapping, and thanks very much, Chris, for pointing out, I had omitted in agenda item 1 about the terms of reference. So just to recap, we have updated the terms of reference for the Health and Wellbeing Board today, really to reflect some legislative changes, which are the Health and Care Act of 2022 and the National Health Service Act of 2006, which are for noting, but I guess raising the point that Chris has raised may need some further discussion. Okay. We do have plans to do a more detailed terms of reference review, which we are hoping to be able to bring in time for the next Health and Wellbeing Board. But actually there's just these changes today are really just to refresh in terms of the legislative changes and for noting. Does anyone have any questions on that before I move on? Okay, great. So moving on now to questions from the public. So my understanding is that no questions have been received for this meeting. Is that correct? Yeah. Okay, great. So now moving us on to the substantive items and welcoming Hilary Ross from NEL ICS, who is going to give us an update on the NEL Joint Forward Plan. Now, you may remember that Hilary came to us in previous Health and Wellbeing Board. I think it was before Christmas. Sort of time to talk about the work that had been happening. So welcome, Hilary, and the NEL Joint Forward Plan has been circulated as part of the pack. So over to you.
Thank you very much, Chair. Can you hear me okay?
Yes, we can.
Brilliant, thank you. So that's right, I attended one of your previous meetings a while back now to share with you our emerging integrated care strategy and to get your feedback on that. ICSs are also required to produce 5-year delivery plans for their system, which set out how they're going to deliver their strategies, as well as all of the wider NHS requirements as well. So we have produced, and what you have in your pack is a first draft of our 5-year plan or joint forward plan, which we completed at the end of March, and we have been taking that around place-based partnership meetings and health and wellbeing boards to gather feedback, particularly around how it aligns to your local priorities and where people feel a system plan can add the most value to local work. So a couple of things just to note. It's been a very quick process this year because of the sort of, because of where we are in terms of our establishment of the ICS, the ICB, the ICP, etc. And the sort of rather late guidance that we received, but we will be refreshing the joint forward plan annually, and we've already started our process to look at the process for next year and future years. We've got a big workshop on Monday where we're bringing partners from across the system together to look at how we do this process in future, building on some learning that we've pulled together from this year, including a big survey that's gone out and an after action review. And we're really keen that in future we have more time planned in at an earlier stage to really support engagement and to have that sort of logical flow from our 5-year plan into our sort of operating plans and our annual plans. We recognise there is more to do to align some of the programmes that we've set out in the plan with our agreed strategy, and also to strengthen social care input, which we envisage would be largely via our place-based partnerships. We've also heard some really key messages about how we need to how I think it's been valued that we've shared the level of detail that we have, but also that we really need to make sure that the document, the main document in itself, is more accessible, but also that we have a very much more accessible and plain English version of the document that we can share as well. And I'm pleased to say that the final version of the Joint Board Plan, which incorporates all of the feedback that we've had so far, is shorter and will be on the website tomorrow. We will also have a very, very brief sort of handful of slides version that we will publish on our website as well, with hopefully 0 acronyms and so on. And I think so this is really, so today is really about sort of hearing your feedback, both to feed into the sort of process for this year, but also to help us shape how we approach this work next year. Just to say that the City and Hackney Place-Based Partnership, we had some really helpful discussion about where we'd got to so far with this work. And as a result of that, we have managed to strengthen in the final document what we've said about sustainability is one issue that came up in your local place-based partnership. We've also strengthened and included more of the work around health inequalities. We've included some more on research and learning, and that's something we want to build on for future versions as well. But I'll pause there and really keen to hear your feedback. Thank you.
Great, thank you, Hilary. So opening now to questions, comments and feedback from the board. Yep, Councillor Kennedy.
Yes, thank you ever so much. I'm having a second bite at the cherry at this, really, having fed back at the place-based partnership as well. And actually, one of the things is I was at the Westminster Health Forum earlier in the week, which was looking at ICSs and the way forward and how they are successfully or not relating into plans and everything. And a key sort of reminder there was that in the initial legislation that set up ICSs, you've got those 4 pillars that they're aiming to try and achieve: improving outcomes in health and healthcare, tackling inequalities, productivity and value for money, and then the 4th one, helping the NHS to support broader social and economic development. And reading this forward plan again, having relevance to those 4, it was that 4th one that I think in our local system, we've got a good story to tell about how we've used some of our NHS money to help fund the Money Hub and the officers that are doing that broader social and economic support in the cost of living crisis. So we're doing it here, but the forward plan doesn't talk about how we might do that in a more planned and ongoing way to support particularly that one of those 4 things. I can see you're taking it around all the place-based partnerships, because in our papers at 2.1, you talk about Tower Hamlets when you do mean to talk about City and Hackney. That's just that's a quibble. And my final point, actually, I did the maths on the capital and the estates money that you talk about in the paper. So on page 49, you point out how we get a relatively low capital budget. I think you were comparing us to other ICSs. So it's only in at 90 million a year. But then on page 64, when we estimate what we think we're likely to be asked for from various parts of the system, we think it's up at about 3 billion. So I think there's and it might relate actually to the new points in the guidance that Chris has just pointed out about the system having to tell us what their estates plans and their capital plans are, and us then being able to have a little bit more of a say in that. sorry, that's a long-winded say of me saying, in the plan, I think you need to join up better the mentions to capital and estates work and where we might have some levers on it. Thank you.
Hilary, if it's okay, I'll just take the other questions and comments. Is that all right? And then you can come in. Francis. Oh, you're just on mute, Francis. I think we can't hear you.
Yeah, I've just got a couple of observations. I mean, it seems to me to be primarily a plan for service provision rather than health and well-being, which is okay if that's what it's supposed to be, but that's sort of not what it says it is. Secondarily, both the summary of the work and the main body contains very little reference to prevention or to voluntary sector involvement. Just as an example, there's a discussion of long-term conditions and about how there are increasing numbers of long-term conditions and how to treat that rather than to take a prevention approach. I mean, clearly there's a role for treatment, but it's also important to plan to prevent long-term conditions, which can be done by including non-medical interventions in a variety of ways. Similarly, that's true for mental health as well within the body of the document. And thirdly, you've got various, well, one or two mentions of co-production, and I know that's the current buzzword, but I have no idea from your document what that might mean, what it would consist of, and who you co-producing with. I mean, obviously I know what co-production means, but it's sort of unclear within your document what you were referring to and whether that's real or whether it's just a buzzword.
Okay, thanks, Francis. Anybody else? Yes, Chris.
So, Hilary, recognising the huge amount of work that's gone into the document, it is obviously responding to national guidance, but the one area that I think is very exciting is the workforce plan. I think if we do get the much promised NHS workforce investment and plan, it will be a huge opportunity. But clearly, a lot of the services that are struggling to provide the quality and the breadth of services is because of workforce issues. I think the anchor institution opportunities for us to grow our own workforce, recruit and train people locally is huge. It would be great to see a little bit more on the workforce and how we can use all of the council's levers, education and people who are new migrants into Hackney, so that we can actually address what is clearly one of the significant factors that is causing difficulties in service provision, which is the staff crisis.
Thanks, Chris. And I think just to echo Chris's point, yes, we can see an absolutely huge amount of work that's gone into this and thought and planning around it. So please do pass on our thanks and gratitude to the team, Hilary, around that. The only thing I would add was just on the points that Councillor Kennedy made around the work of Money Hub. Actually, we also have some fantastic case studies which really demonstrate how the innovative use of health resources to fund the Money Hub have actually realised huge life-changing amounts of money that people were entitled to actually coming into their pockets, but actually into the ecosystem within Hackney. And I think that, there's one example which was given, of actually a gentleman, it's not my example, so I'm not going to take any of the credit, but a gentleman who hadn't appreciated that he was eligible for pension benefits and hadn't sought these for a long time, and actually through the help of the Money Hub was able to have back pay around this, which amounted to close to £100,000. I mean, these are life-changing amounts of money to which people have been entitled to, and actually it's really about how do we support residents, and this is also in sustainable ways. The investment through the Money Hub inevitably creates sustainability for our residents, which I think is a key part. So it's just, if you're looking for examples or things that, if you're in the forward plan to bring things to life around the one on the broader social and economic development, we really have amazing case studies here. But I'll leave it to you now to come back to some of the points and questions.
Thank you ever so much, everybody, for really, really thoughtful and helpful points raised. Just on this point about health inequalities and specifically some of the sort of challenges around cost of living increase at the moment, we have strengthened what we said about health inequalities in the sort of final version based on a lot of the feedback that we've had. You'll remember that it was one of our priority cross-cutting themes in the integrated care strategy. We gather insights and examples from each of our place-based partnerships that they come to our Population Health and Integration Committee. So our board is cited on some of this good work. We've also got a board development session coming up on health inequalities, and it's interesting because the Money Hub in Hackney is one of the things that I've used as a study, because it does sound like a fantastic piece of work, and it does tie in with some London-wide work that we're involved in through the London Health Board as well, which will be focusing on benefit uptake and things like that. So it's really great to be able to highlight these case studies, to be sharing those across the system as well, so that others can learn from your experiences too. And we're really, really keen to do that. The good news story on health inequalities in North East London is that we have as a system committed to providing funding for tackling health inequalities for over the next 3 years. As far as I know, we were the only ICS in London to have done that. And this is in recognition of the key role that community and voluntary sector partners play in tackling health inequalities, and the benefits to having a bit more of a sustained funding available to place-based partnerships for doing this really, really important work. So that's a really positive thing, and we've said a bit more about that in the joint forward plan. The stuff on capital, you're absolutely right. We're in an active and positive discussion with NHS England and regional partners about that at the moment. We are, and there's some points around sort of co-production and health inequalities and working with the community and voluntary sector. They're all really, really key in our strategy. I think we've got to where we've got to in relation to our delivery plan. There is more work to do to align all of that transformation work that we're doing across the system to those priorities and principles that we've set out in our strategy. And I think, so those are areas we absolutely want to strengthen. We do, in terms of working with local people, we have drawn on all of the insights through our Health Watch colleagues for this version of the Joint Forward Plan, but we're also working with local colleagues to hold public events in each part of our system to hear more from local people about what's important to them and what they think about some of the themes coming out of our strategy and delivery plan. Workforce, and finally, workforce, absolutely critical. There has been a parallel process to the development of the Joint Forward Plan to develop a workforce strategy for North East London. That's been a really participative process, and more of the output of those discussions is included in our final version, including those really important bits around the sort of anchor institutions and that opportunity to increase the amount of local people having access to roles in health and care in North East London. But really, really helpful feedback. Thank you very much.
Great, thanks, Hilary. And when can we expect another, when might be another sort of gateway or timeline when we might get an update, or later in the year, or just to get a sense from the board perspective?
Yeah, I mean, we're keen. I mean, we're happy to come back to provide updates and to continue the dialogue throughout the year. We will be publishing the final version imminently, as well as the accessible version. There's more work happening over the summer to design our planning cycle for next year. We've got a workshop to co-design that on Monday. There's going to be more work around developing an outcomes framework, which will enable the board to track progress against our strategy. So that any time is a good time for sort of for continuing the dialogue about this, but really the autumn time will be when we start our sort of planning in earnest for next year.
Great, thanks very much, Hilary, and for all the work that's gone into this. Okay, moving us on now to the next agenda item, where we're going to hear the Director of Public Health Annual Report, Healthy Sexually, and Danny Turnton is going to present this, and Sandra's going to do the intro. Just a couple of things. So we're going to take this item and then the Sexual and Reproductive Health Strategy and Framework after that, and then we will then look to have a discussion after both items. So over to you, Sandra.
Yeah, thank you, Chair. And just to remind you that there is a decision to be made around the strategy, but not the report. And if we could not forget that when we come to the discussion after, that'd be helpful.
Please remind me if I do forget, but I'll make a note of it. Okay, thanks.
Okay. Thank you, and thank you very much. This is my statutory regular annual report. This year it's about sexual health, and Danny, who's one of the registrars that's been with us, has done basically all of the work on this report and will present it. Just to remind people about the nature of these reports, it's a statutory requirement, and it's a report from me as an independent professional, and the responsibility of the local authority is to publish it. So we are bringing it here. It is in draft for to pardon the phrase, socialise it a bit, and to have the discussion. But the report and the record are ours from a professional perspective.
It's the bottom right square. It's got like a little hand and a face on it.
I think I got it. Thank you very much. Good afternoon. My name is Dan. I have the pleasure of presenting this draft annual report from the Director of Public Health. So, as we just mentioned, the report is this year on sexual and reproductive health, with a focus on younger people and sexually transmitted infections. You have a copy of the draft report in your packs, but I'm just going to give a little background, explain why the subject was chosen, how the report was drafted, and highlight the recommendations made within it. So, why look at sexual health? Well, we know sexual and reproductive health is important for the whole community and across the entire life course. What's more, in the city and Hackney, there are significant sexual health needs compared to other areas in London and in England. And I want to show these graphs just to illustrate that point. This slide shows that Hackney and the City of London have recorded higher rates of newly diagnosed sexually transmitted infections than the England averages for the past 11 years of available data. The red dots on the blue lines represent the rates in Hackney City on the right, while the black lines and the black dots represent the latest available data was 2022, when the OCs locally was almost 5 times the average for England and more than double the average for London. So that's the need, but why focus on younger people access sexual health services locally more than other parts of the community? When they do access those services, they are more likely to have an infection and more likely to require treatment. At the same time, Hackney and the City have relatively young populations, with over 34% of the population under the age of 30. And we have a relatively sexually diverse population as well. The proportion of gay or bisexual men in Hackney and the City is over 3 times the England average, according to the most recent census. This slide outlines the process which informed the report, and it was through this process that the recommendations were formed. One important theme which was emphasized during preparation of the report was that access to services, particularly sexual and reproductive health services, is determined by both push and pull elements. In other words, the barriers to accessing services relate to people's own communities or people's own beliefs, and just to the way the services themselves were set up. This is explored within the report and addressed in the recommendations. And so to the recommendations. There are 5 broad recommendations coming out of the report. The first recommendation is about the need for working with communities for co-production and collaboration with the people we serve. This is a fundamental principle and should underpin any of the recommendations put forward in the report. The second and third elements of improving people's access to services, the push and pull elements I've already mentioned. Services must be well designed, accessible and inclusive on the one hand, and on the other hand, people must know about those services and be willing to access them. The fourth recommends even greater collaboration between people and organizations providing sexual health services if we are to improve the outcomes and experiences people have of those services. That is, if we are to improve services, notwithstanding the significant pressures, both staffing pressures, which we've mentioned, that those services are currently under. The fifth recommendation highlights the need for ongoing evaluation and research done in collaboration with our communities to identify inequalities and share that information that is uncovered between partners. And of course, it is crucial that research of this type must be backed by a commitment to address those inequalities that may be identified. Thank you very much for your attention, and please save discussion for after the following presentation from my colleague, Fruits.
Yep, thank you. I'm again finding myself having trouble with the share function, which, if you've got it, it worked really well this morning. So we operate as a team. We try to.
And just checking, can everyone online hear? You might want to move the microphone just a little bit closer.
I'm usually quite loud. So, but I know it's necessary for technology to use a microphone, but yes. So thank you for your time today. My name is Fruks Kamenga, and I work with Danny and Chris on sexual health in the City and Hackney Public Health team. And as he already outlined, well, he's already set the scene for me to talk to you about why we need a sexual and reproductive health strategy for City and first of all, sexual and reproductive health and well-being are fundamental human rights, as are other human rights, and they are integral to our human existence and the human experience, really. And secondly, with the need, we have high need in terms of sexually transmitted infections, but also, for instance, inequalities in active contraception and other reproductive health services, differential uptake in different groups, their knowledge of services and what they feel able to access. And then, of course, we have pressure in terms of finances and resources, and combined with the fact that as a local authority, we have the statutory duty to protect and promote the sexual and reproductive health of our populations. It all works together to come up with a comprehensive strategy to address division. Oh, you've not moved yet. Oh, sorry. Sorry. Oh, sorry. So the vision underlying this strategy is for all residents in Hackney and the City of London to lead healthy and fulfilling sexual lives in which they have knowledge and agency to make informed choices about their sexual and reproductive health and can access high quality services to support them in doing so. Ah, yes, that was the rationale and the vision. Sorry, we get, yes, moves me on to the themes. So what are we focusing on in the strategy? Well, we've done a sexual health needs assessment in 2022, and we have a number of other data sources that we used from our local providers and also from national data sets. And so we know a lot in terms of figures and numbers about what our key issues are. And so the 5 identified are healthy and fulfilling sexual relationships, reproductive health across the life course, STI prevention and treatment, getting to 0 new HIV transmissions by 2030 is the goal, and vulnerable populations. Now, the first 4 themes align also with the priorities of a NEL-wide strategy that is currently being developed. So there's, the synergies there as well in terms of the priorities. And the fifth theme of vulnerable populations, we've added to make sure that different groups who may have more complex needs are taken care of within the services. Yeah, next slide, please. So I will very briefly talk about some of the key issues in those themes. We've already mentioned the high rates of STIs in our young people and young adults, and especially for those young people who are about to maybe start their sexual debut, if they have access to good, inclusive and comprehensive sex and relationship education in schools, that can, and not just schools, also places of alternative provision, that can hopefully help them in some way to get them into healthy sexual behaviors and choices. Reproductive health, we know that not everyone is about the various reproductive contraceptive choices that are available to them, and how can we improve that. And for instance, where there is emergency hormonal contraception or termination of pregnancy, if that is in others, we know that those groups maybe don't have the same access to more reliable forms of contraception, so we need to address that. Treatment, again, the high infection rates, and that often leads to high reinfection. So what can we do there with our young people, and also especially our gay, bisexual, and other men who have sex with men, where infection rates tend to be high? How can we better understand the needs in specific subgroups and make better use of those treatment opportunities or attendances to use them as opportunities to talk about safe sex, point them in the direction of free condoms and other services. There's differences in testing behavior, for example, whether that's by ethnicity or orientation. And in that regard, for instance, we'd like to see more testing in heterosexual men, the worst health-seeking behavior, and in sexual health, that's no different. Getting to zero new HIV transmissions, we've made great strides in terms of HIV prevention and treatment, and we have fewer new infections almost year on year. But you know, in order to get to how do you say that, the last mile, to run the last mile, or we need to make sure that we keep testing in order to prevent late diagnoses that have worse health outcomes. And also we need to broaden awareness and uptake of pre-exposure prophylaxis, which is a very important preventative method, well, obviously to prevent HIV. And that's been traditioned, and the uptake is great amongst gay and bisexual men, but there are other population groups who really benefit from that. So. Lastly, vulnerable populations. That's not a how do you say that? That's a variety of groups that could fall in. They could be homeless people, rough sleepers. They could be sex workers. They could be young people who've gone through the care system. People with use issues. So there's not. The key challenge there is that we don't necessarily have enough information about what type of how those complex needs or their vulnerabilities relate to their sexual health, and how can we better serve them within our overall services. So that's by and large, well, there's a lot more in the strategy, but the link has been provided in your pack. What we would really ask you is to allow us to take this strategy for a formal 12-week consultation period, during which we will also undertake the action planning alongside it, so that when we come back to the Health and Wellbeing Board with hopefully a finalized strategy, we also have an action plan that we can start working towards implementation. So the consultation process, it will have an online survey, we'll do a series of online consultations with a variety of stakeholders, and a smaller number of face-to-face discussions. And then, as I said, hopefully present that to the next Health and Wellbeing Board. And in terms of implementation and reporting, we have an existing sexual health forum. Providers meet every quarter together with some other key partners. And that could be more like the rolling oversight of how things are going. And then have a sexual health dashboard to support that from a data perspective. And and then provide annual progress updates to the Health and Wellbeing Board and get annual approval from the Health and Wellbeing Board for our action plan. And that is by and large my contribution today. And I'm sure, Chris, if you have anything to add, you will. Thank you.
Okay, thank you very much. And first of all, I can see huge amounts of work have gone both into the annual report and into creating the strategy. So thank you again to you and your teams for driving that forwards. So just to clarify, so the Director of Public Health Annual Report is coming for an initial socialising and discussion and to get some informal feedback on it. And the strategy is coming for a decision from the board to approve it so that that can then go ahead for a 12-week consultation. Yes? Great, good. Okay, so opening now to online and into the chambers for any questions, comments, feedback. Please do put your hand up. Raj.
You know, where you got the commission services, I'm not quite sure if you're aware, community pharmacies can now have a nationally commissioned services to provide oral contraceptives. If it's not mentioned in your strategy, you got emergency contraceptives, which is a locally commissioned service that we do through the local authority, but this is a national service. Those individuals are already on the oral contraceptive, don't have to go to Shakespeare Clinic or GP practice. They can come to community pharmacies and we can provide them the oral contraceptive, because there's always been a bit of a challenge for individuals get appointments or they're forgotten on its last minute and etc. So we can do that. I think it's been commissioned, so that's happening. I just wonder if you can add that to your strategy as well.
Yeah, very briefly. I think I don't know if Chris has edited it out, but I did mention it, and we definitely, because we know the pharmacies are so important, especially for young people, to access sexual health services. And then, for instance, if they come for emergency hormonal contraception, in the same breath, you're able to talk to them now about a more reliable form of contraception. So that, yes, is noted.
Just to add, I think the first stage is those individuals already on an oral contraceptive. I think that at a later stage that we'll be able to initiate individuals on the oral contraceptives. I think to start off with is those ladies already on the oral contraceptive, we can carry on with that. I think at a later stage that will come. So again, in part of the strategy, maybe you can just reflect on what I've just said. That might be helpful.
Yeah, I would agree, Raj. I think this is the start of a journey in terms of how community pharmacists are going to be utilised for contraception, sexual health services in a much broader way than they are already. Okay, I've got Tony online. Do you want to come in, Tony?
Thank you. Thank you for the presentation. It's really interesting. I guess why led this question, obviously this focus on young people, so just trying to understand as well. Obviously I understand the rationale, high rates of infections, STIs, so forth, so I understand the rationale behind that. Just curious then, in the background behind this, what work is happening for older people, because I don't know the stats around this, but I'm sure I heard not in the too distant past that there was a new wave of older people who are exiting relationships, either through separation or being widowed, enter into new relationships and don't necessarily have the sexual education that younger people now get. So just wondering what's happening, if perhaps you could just answer that. And then second question, if I may, just interested, part of your presentation, you talked about the different rates that relate to different people from different ethnic backgrounds or where they live in the borough, or by age, and presumably, again, you're talking about young people. So if perhaps you could unpack that a little bit. And third question, if I may, sorry, co-production you mentioned, great. Just want to understand how will that involve the VCS, because obviously they have a lot of links to the youth sector with some of the young people that perhaps would need to be reached through any co-production activities. Thank you.
Hi, Chris, do you want to come in?
So apologies for any confusion. The DPH report focuses on young people because we wanted to have it as a punchy report that wasn't too broad. The strategy is a strategy from the whole of the life course, including preconception all the way through to older people, and also menopause services. So it's a very comprehensive strategy.
It is supported by quite a comprehensive needs assessment, which is on the website, and we have also got a plain English summary. So for the consultation process, what will go out is the needs assessment, which does cover very broad sexual health and reproductive health needs, plain English summary, the strategy itself, which does, I think, still reference national, very welcomed national developments around oral contraception, continuation in pharmacy, but also there is aspirations to do a lot more in community pharmacy as well. So apologies, Tony, for any confusion, but we just put the two together because it's quite an interesting way of sequencing the fact that we do know there's lots of STIs and unmet need in young people, but you're completely right, there is a need for a complete life course approach. And I think the other thing to kind of stress as well, because it's been nice to have the ICB forward plan, is a lot of the work that we want to do and in order to actually get the vision of the strategy, you can't do in isolation. The sexual health services are an example of lots of different commissioners where you come together and you provide services which are in partnership with the community in co-production and also with all the commissioners, such as the Women's Health Hub that we have in Hackney that was visited by the Minister for Health, Women's Health last week. You get an excellent service because you're not really that bothered about actually whose commissioning responsibility. What you're bothered about is getting the best outcomes and the easiest pathway. So the strategy is comprehensive, and because of that, it sometimes does feel a little quite detailed. The action plan is important because we want a 5-year strategy. We can't do it all in the first year. So we are going to have a decision with the Health and Wellbeing Board about resources and priorities in order to be able to get the strategy to deliver, but also making sure partners are true to what we want to do in the Health and Wellbeing Board, which is integrate and improve health and wellbeing and get better services for people, as well as focusing on prevention and making sure that when people access services, that they get the full range of services rather than it being we can't do that because of this. And so, I think the strategy and Frux's work to try and get this to be a North East London interface strategy as well is important, because we have unique needs in Hackney and City, but actually quite a lot of what we need to do is quite similar to Tower Hamlets and elsewhere. So if we do work in partnership, have a similar strategy that we can adopt across North East London, then some of those issues around community pharmacy, for example, we could probably do once rather than having to do 7 or 8 different times. Thank you.
Thanks. So actually this year's annual report puts a lens over a specific aspect of the broader sexual health strategy, but actually given we're having a launch of a strategy, actually the annual report provides perfect opportunity to highlight some particular aspects of that and really kind of shine the light and get people to focus on it. And Chris, I think you made some really important points, which were going to be some of my questions, were just around how do we integrate the sort of more historical way of working of services and commissioning, so that actually we're not creating silos or multiple silos. And the Women's Health Hub is a really good example of that, because actually the person, the patient, the resident doesn't really care or should worry about actually who is it who's providing it. It's actually the journey that they're having is very smooth. They're seeing the right person in the right place. They're telling their story once, all of that. So I guess one of my questions in thinking about today's session was where do the resources come from? How do we start to do that, recognizing that resources are finite? And actually, is it about, in the first instance, thinking about how we pull together or think differently about the resources that we have, how those might be utilized? Is that the sort of starting point? And I guess my other question was, how do we as a Health and Wellbeing Board really support that and really sort of drive that, subject to, as approving the strategy today, actually, how do we really start to drive that work forward, recognizing, the kind of partners around the room? It's not necessarily that there's an answer to all those questions, but I would really welcome people's thoughts. Chris?
So you're right. Every time we get a national strategy, it often feels like an opportunity. So pooled budgets were potentially the language we're talking about. I think they have sort of moved away from pooled budgets. And I think the co-production lens is a really good way. So if you start with the resident or the patient,
you start with where do people want to access services, what's necessary for people to access services, so some of the knowledge and that we're promoting services as being open and accessible. But the Women's Health Hub, I think, is a really good example where you design the services around the individual and then you join up the commissioning. Actually, when you do that, you'll find that it's almost certainly a more efficient way of providing services, because the consequences of poor sexual and reproductive health are huge. So they're not just in terms of the individual, but wider society, about unplanned and unwanted pregnancies. So if you actually take the co-production approach that design the services with the people that need to use them, I'm very confident that you end up with a service that actually is then more cost effective than what we have now, because at the moment you can't make the services join up very well because there are just too many silos, and you spend forever trying to produce leaflets, etc. And it doesn't work. I mean, if somebody's accessing community pharmacy for emergency hormonal contraception, that's the ideal time to have the conversation about what else you need to provide, rather than saying, no, we can't do that. You have to go and see this person, this person, and this person, and then nobody's really very sure where the service is, what time it's open. So I think designing the services with the patients and the residents at the centre, then joining up the commissioning, and if necessary, holding people's feet to the fire so that you are getting the money following the pathways, is definitely the right way. And anything else, in my experience, you just end up with very complicated conversations about MOUs and budgets, and it's the wrong way around. So co-production, patient, resident at the centre, design the services, and then as I said, I'm confident it ends up with a much more efficient and effective service.
Baz.
Hi, that's Dick here from the Homerton. I would just say that I echo and support that approach. I think that's absolutely the right way to do it. And it's easier for the clinical teams and all of those who are involved in delivering that service, if that's what we're doing. If we're bringing people together around designing the service around the needs of the individual and the community, it's a far more effective way to do that, and for those clinicians. And then you're absolutely right, the pathway is just streamlined. I haven't been to the Women's Health Hub, but I hear good things about it, that is one of the things around it. Everybody's there to deliver services for those patient groups and for that population. So just wanted to say that I welcome that approach, and I think it's
Raj.
I just want to echo what Chris has just said in terms of thinking about when people present themselves at our pharmacy for an emergency contraception. I can do anybody at any age for the emergency contraception. But if they wanted a chlamydia screening test after above 24, I'm unable to do it because it's not been commissioned. That's kind of things that, again, I can pick up, and I think we can open that up. All being well, we can do it, thinking about how we're doing things. It will help individuals then having to go to another provider for kind of things like this. And people struggle all the time, and especially this pandemic, things like it's been absolutely manic of difficulty for people to access those kind of services. Hopefully, I like the idea of what wrapping services about the individual and think about what do they need, where do they need it, and then think about a provider that can provide that kind of service. And I think I'm not just talking about sexual health, but you're talking about long-term conditions, whatever the service you're talking about. I think we need to think about, put the patient in the middle, and then think about who is going to provide the rep service around those individuals, wherever they might enter, whether it's a community pharmacy or a GP practice, social care setting. I don't know, it could be anywhere. And I think we need to come together as a health and well-being as to where we can make that difference.
Thanks, Raj. So I think what I'm hearing is that everyone is very passionate actually about this as a topic, and recognise the importance of all this work. Because as people have already said, that actually when sexual and reproductive health isn't done well, actually the ramifications of that across the whole of the, I don't like the word system, but across the whole of the ecosystem, actually it's felt by lots of different people. Francis, do you want to come in? Oh, you're on mute again.
Yeah, just one quick question. You highlighted the reluctance of heterosexual men to attend whatever services are available. I'm just wondering if you've got any thoughts about how to address that.
That's the million-dollar question. Yeah, we may have to get creative about it and maybe speak to heterosexual men to see what would make them, what would take down the barriers for them to access that. And actually, pharmacies, again, are a place to start, because even though chlamydia screens have dropped since the pandemic, when people do go, the gender balance in the take-up of screening is much more equal in pharmacies than it is in sexual health clinics, for example, which may also be because women go for other reproductive reasons to clinics. But yeah, I think low barrier access is always a good place to start. But it's certainly something that we'll throw into the discussions when we go for consultation, and see if people can come up with new and innovative ways to entice other heterosexual men to come forward for testing and treatment. Thank you.
Great.
Just to add, I mean, sometimes the national policies don't make a huge amount of sense. So heterosexual men are no longer in scope for the national chlamydia screening program. It's meant to be focusing only on females, which doesn't make a huge amount of sense when you talk about gay and bisexual men, and also doesn't make a huge amount of sense about encouraging health-seeking behaviour and responsibility. So we have listened to the guidance and then interpreted it locally. So we are very keen to encourage heterosexual men to continue to test for chlamydia, because in doing so, it also makes sure that people are aware of, biologically it's fairly straightforward how things are transmitted, but in terms of policies, there are sometimes some of the national policies that don't make a huge amount of sense. And I think in terms of gay and bisexual men as well, because we have got a very large population in Hackney, some of the healthcare seeking behaviour is very good. Gay and bisexual men going and getting testing online, using PrEP. But we do also need to understand a little bit more about which of the gay and bisexual men need to get tested a little bit more, how we can make sure services do go to all of our communities, which is why we have got that strategic area around vulnerable populations. So it's difficult to get the language right. High risk is definitely inappropriate. But I think we are very committed to, again, the co-production and working and understanding the needs of our local population and trying to get services designed around those local.
And you only need to look at the slides that Danny presented around the differences between England average and our local averages to really understand why it's appropriate to listen, to understand the rationale behind national guidance and national advice, but actually putting that local interpretation on it so that it's actually meeting the needs of our local population is totally key. Okay, so I guess when we come to the decision-making bit around the strategy, I guess the question I always ask myself is, how do you make the strategy a reality? How do you really start to, over a 5-year period, not only in terms of the recommendations that come from the annual report, but also the work that will need to happen around the strategy? How do we make that? How and when do we identify the opportunities for exactly the work you've talked about, Chris, which is finding when co-production is needed? So I suppose it's, will the action plan start to think about where and how opportunities might arise for things to happen? Because you say it's not about MOUs, it's not about, concrete things, that actually it's about following the co-production and basing it around the resident. Will the action plan cover sort of those things?
So I think you're right to highlight that strategies sometimes don't live beyond the pages of the strategy. I think the sexual health strategy, because you do need education to ensure that you've got the education involved in order to ensure you've got sex education, right and appropriate in schools. So I think it is a really good test of, have you got an effective health and wellbeing board? Is sexual health is a really good example, because you can't do it in isolation. So I think the idea that, it's going out to consultation, it's coming back in September, it then gets formally adopted, and that you also have the action plan, and that you then do challenge each other and partners to make sure that everybody is actually doing what they've agreed to in the action plan. So it will be aspirational. It will have to deliver over 5 years. Resources is going to be part of the challenge, because we are going to be looking for some communities to have higher rates of testing. That will cost potentially more money. but the savings will be there in terms of reduced STIs and reduced unwanted pregnancies, better access to contraception. So I think it is important that, yes, it's not just a strategy that's adopted and then left, it's a strategy that then comes back. The dashboard that Frooks has talked about is going to be really important, and the dashboard being owned by all the partners, including education, the youth service and others, so that it is, you know, a multi-agency strategy that only works if all of us, you know, really are committed to delivering what's in the action plan and hold each other to account on at least an annual basis.
Thanks, Chris. That's really helpful because I think that really starts to articulate and outline the role of the Health and Wellbeing Board in this incredibly important piece of work. So really, and I think that's really helpful for partners to hear, listen to, and start to understand, and something we can come back to then when the action plan comes back. So it's actually, how do we as a Health and Wellbeing Board support, drive, critical friend, do all of that role to the partners around the table to make sure that actually where that co-production, making sure that is happening, which then in turn leads to service delivery, but we don't start with the service delivery point. Any other questions or comments on that? So in terms of the decision-making bit, I am assuming that the Health and Wellbeing Board approve. Yes, sorry. Do you want to pop your mic on?
Thank you, Chair. Forgive me if I got it before. Just thinking about if there were any sort of bespoke or interesting approaches that you were able to use or think of that will drive the uptake of people getting tested, because we're talking about health and wellbeing and we're quite open and been transparent, but it's still sometimes in some communities still a bit taboo around the subject, and how do we manage that and how do we navigate that while being sensitive around some people's views and how a subject like this might be discussed or felt within communities. Thank you, Chair.
Sandra, do you want to come in?
Yeah, thank you, and thanks for the question, Councillor Bramble. Well, we already work and commission local small community organisations who have particular relationships and reaching communities. And then, of course, through the process that we intend to go through to develop the app, we will be working with community members to help us determine what those particular bespoke arrangements should be.
Great, so we're happy to approve the strategy assessment within the TILs, and then the 12-week consultation can start. And in terms of the annual report, I think really welcome to have the opportunity to have the discussion here today and really focusing that lens on, and I guess some of the things in the annual report, some of the recommended actions then link in with what will come after the consultation as the wider action plan is developed. So thank you very much, because I can see a huge amount of work has gone into preparing that, so thank you. Okay. Moving us on now to the Neighbourhoods Programme response to the HCBS Connect Hackney recommendations, and welcoming Sadie King.
Hello, thank you. So hopefully you've received the report with lots of connecting links in there. I'm just going to go through the key points. So the aim of this report was to make clear how the Neighbourhoods Programme is delivering some of the key recommendations coming out of the Connect Hackney evaluation, and to really check in with the board on how you would like to receive future reporting through the new Neighbourhoods Programme outcomes framework and evaluation. So there are 4 particular recommendations that really align with the programme of work that's currently going on in neighbourhoods, and they are the issue of home visits, offering home visits more in navigation systems, the provision of community languages in navigation services, and finding solutions to barriers between navigation offer and community activities, and then a really broad one on embedding all of the recommendations around addressing social isolation into the design of activities, and in particular proactive strategies, provision of regular meaningful activities, and really the activities should be not just one-off, but a lifeline to really sustained social connection for people. So really building capacity for people to be connected in their communities. So a quick background on the programme, which hopefully you all know quite well. It's now in year 5, there are 8 neighbourhoods connecting community services, delivering on the footprint with the PCNs, and there's strong resident engagement through community neighbourhood forums, collecting insights and producing reports. There's multidisciplinary team meetings, and there's sort of a growth disciplinary practitioners that know each other and focus on these small populations, really trying to understand the health inequalities and working more efficiently to address them. This year we've produced an outcomes framework, and there's an independent evaluation in place which hopefully we can monitor some of these recommendations through. So I'll just go through the 4 comments on the 4 recommendations and how the neighbourhood programme addresses these, begins to address some of these. So the home visiting issue. So there are around 30 community navigation roles in City and Hackney. In the report, there's a link to a guide that explains all of them. They're all different, and they all have different policies on home visiting. The new social prescribing service has this in the service spec, but since October, there's not been much demand reported at all so far. So we need to continue to monitor this. There's a new outreach service there too, and they are currently recruiting volunteers. And we think that really through the volunteering, home visiting capacity could be increased if indeed that's what's needed. We're also looking at through our OD programme, improving the links between those navigator roles, so the social prescribers, the wellbeing coaches, etc., and the statutory service. So there's a lot of work to do to bring them together through the structures in the neighbourhoods, so they can be more connected to services that home visit anyway. So it's the link between those navigators and those services. We are doing more work to improve the way we collect insights around the need for home visiting from those roles. There's around 120 people in those roles in City and Hackney. So the second recommendation was around community languages. So we believe, I mean, the providers are reporting that this sector is very diverse. So there is a lot of inclusive recruitment going on and recruiting from particular communities that we know are experiencing greater health inequalities. And the Neighbours programme is supporting this through the OD programme. So there's a pilot on inclusive recruitment that's developing materials that value lived experience. So we've piloted that within the proactive care pathway and recruited local people with local experience, including language skills. Also the pilot on anti-racist service design, that's going on at the moment in women's health and in the CVD pathways. And again, this, you know, the idea of this is to identify barriers, to co-produce services that are relevant, that work around the assumption that there is embedded racism in the service pathway, and it's not the particular communities that are the problem. So redesigning the pathway around the resident, as has been described here in earlier discussions. The MEC training is also being adapted around neighbourhoods to address local barriers. And there's a really important piece of research going on at the moment by Renee Say, looking at barriers to taking up preventative services, and this is focused on 50 plus age group. and the results will be due in September, and we would expect that there would be some insights on language barriers and recommendations on how to address that. The third recommendation to speak about with regards to the Neighbourhoods programme is overcoming the barriers between those navigation roles and what they can do with that service and community activities. So are there enough community activities? What is the barrier? Again, we're talking about barriers. We have navigators, people can go to them, they're referred to them, but still, are the right activities there? Are people able to take them up? The neighbourhood's response to this really is an enabling one. So it's about building organisational structures that focus on the development of a multidisciplinary team, all focused on one smaller population in a neighbourhood. All the professionals know each other and they can respond to barriers efficiently. So the structures in place that are being developed this year are neighbourhood staff meetings, neighbourhood navigation networks. We now are putting in place leadership groups, one in every neighbourhood, who are really looking at population health management approach and understanding those health inequalities and creating priorities. The neighbourhood forums where resident voice is strong, and we're also looking at co-location of services, so bringing the voluntary sector and those navigation roles in much closer continual contact and working together with the same aims as the statutory sector. The last area is the broad one of embedding the recommendations on addressing social isolation. So some of this is a little bit repeating some of the other parts that I've said. So the OD programme, I've mentioned the anti-racism project, the inclusive recruitment. There's also a programme developing resident advisors who are really genuinely supported and developed with sort of peer group, community practice and professional training on quality improvement, so they can participate and in fact lead care pathway improvement work in a meaningful way. And local inclusive leadership, multidisciplinary working. The community navigation strategy is really focusing on developing the capacity of that sector and improving the links with the statutory sector to respond to local need, and understanding that local need in each neighbourhood. And of course the forums generating insight and already generating a number of co-production and improvement projects that are addressing health inequalities in the neighbourhoods. A couple of those mentioned in that report. But the most significant piece of work at the moment is the proactive care pathway, because this really identifies a cohort in every neighbourhood of moderately frail people over 65, and in some neighbourhoods it's 50 plus because of more biological ageing. This pathway is one that is not just or targeted at people who will take up services, but holds in mind and proactively approaches with sustained engagement people who are not taking up services. And there's also 2 innovative enabling pilots happening as well. So one personal budgets and one frailty awareness training for all people who live in a neighbourhood to really be empowered to provide community activities for people who are frail. And this will be evaluated over the next 2 years. That's all of the areas that the Neighbourhoods programme aligns with very clearly. So happy to discuss this or think about ways you would like to see more detailed reporting on this in the future.
Great, thank you very much, Sadie. So opening now to questions, comments. Sandra.
Thank you, Chair, and thanks, Sadie. Really helpful report. My question is about the home visiting bit, and that although this is already provided for, you said there's been quite low uptake, and it's not clear from the report or from what you've said whether people are not taking up the offer because they also couldn't take up an offer beyond what the social prescriber or community, the interaction with the social prescriber or community navigator, in which case they don't see the point of having a home visit from someone, or whether there's is it as fundamental as I can't get out, so don't bother coming to see me anyway, or is there something else that's going on?
Sadie, if I just take all the questions first, is that okay? Tony.
Thank you. First of all, thanks, Sadie, for the report and the presentation today. Really interesting to kind of see the commitment of the board and yourself as the neighbourhood programme lead in committing to the recommendations that came up Connect Hatley. I guess, yeah, just a couple of things. Really interested to the response to Sandra's question, actually, but from my perspective, I think it's useful to make the distinction between loneliness and isolation. Loneliness is really a subjective feeling about how one feels about their level of, social connections and the value of those. And then social isolation is more about how the number of opportunities people have to connect with other people. So I think what you've highlighted through your presentation report, I think talks largely to the isolation component about, a number of activities on forums where allow people to come together. I think the nuanced part of the loneliness side, which was also part of the Hatley evaluation, was how those forums then allow relationships to form. So it's a soft output about the time that people have to kind of network informally outside of formal agendas, for example. Are there specific coffee or food that's provided that allow for those kind of ad hoc conversations to happen outside of formal agendas. So yeah, I think that's a piece of learning that perhaps we can work with you on in terms of the involvement that we have in the neighbourhood forums actually to take that forward. But yeah, I just wanted first and foremost just to say thank you to the board for adopting the recommendations, and it's good to see that there's commitment to seeing how these are playing out within the systems. So thank you very much.
Great, thanks. Councillor Kennedy.
Likewise to say thank you very much, Sadie. This will form a very important part of the work that we're doing in our social connections, social isolation group that Joya Dessar from Public Health is leading as we look at how we properly fulfil that reducing social isolation target, which is one of those three main things that we want to do as part of our health and wellbeing strategy. And we always have to remember, actually, as a board, that one of our main targets is fulfilling our strategy objections. And I'm really glad that Tony picked up on the difference between loneliness and social isolation. We do need to remember you can be lonely in a crowd if you don't feel connected to them. That can be absolutely very physically almost the opposite of being isolated. The proactive care pathway, I think, is really interesting in this field. But this whole report, and especially about take up of home visits. In our first meeting yesterday, we heard examples of really useful home visits that had transformed lives, but the people whose lives had been transformed hadn't asked for a home visit. It was something that had come from the community organisations who work with them. And that's absolutely a key part. There's very often the people who most need the help that is provided by those organisations can't even ask for it or don't realise it's out there, or that they could ask for it. So it's really important that we work on those, that we get those pathways to find those people.
Any other questions, comments, or feedback? No, yeah, just I would really echo all the other points that have been made out. Equally, I think we have around 1,500 roughly housebound patients on GP practice registers, give or take a few hundred either way. I can't remember the exact figure, but actually as part of that, they are visited proactively at least 4 times a year and by the members of their GP practice. So I wonder if that's something that we can weave in a bit more concretely into that work that's already taking place, to also asking the questions and understanding if people were aware of help, or actually, which relates to Sandra's point, what's people's perceptions of what they need or what's available to them. And some of those may be assumptions that because they're housebound, that actually they can't then access other things. And so it might be worth making some of the links with that work. Because there's already people going out to see these people proactively. And it's something that can then easily be incorporated as part of that work. Okay. Anything else on that? If not, we'll move on. Nope. Okay, so now moving on to, it's quite a big title to say the future of the Health and Wellbeing Board, and it's down to me to talk about the future. Wow. I think if we think about some of the examples that we've talked about earlier in this meeting, we've talked about from a service and commissioning perspective, how do we make sure that things aren't siloed? How do we make sure that all the different bits of the systems are working in the most effective way, and really utilising, leveraging relationships and ways of working? And I think the same thing absolutely applies to the Health and Wellbeing. So it's actually thinking about how do we as the Health and Wellbeing Board make sure that we are spending our time, our effort, our energy into things where we can make a difference. And who else or what other groups is it across City and Hackney that can support us to do that, and how perhaps do we build relationships and ways of working in different ways than we already have now? So in line with that, and maybe others, we've had some pre-discussions around this, so there may be others in the room or online who want to contribute to that, in really thinking about what relationships do we want to build in terms of our health and care board, which then links in with our neighbourhood health and care board, in the first instance, to think about how do we want to build that relationship in a different way, perhaps so that we are then free and able to take a much more driving role in the strategic direction and setting that. But actually, when it comes down to, we might use the action plan as a good example, when it comes down to some of the really tangible delivery aspects around health and care, how can we build the relationships with other groups so that actually some of that work on much more of the sort of granular detail perhaps is happening elsewhere across the place-based partnership? I guess Councillor Kennedy, Sandra, Chris, I hope I've articulated that in an easy to understand way, and would really welcome about functions, about roles, and how we really make the most effective use of people's time, but really have the most impact. If anyone else would like to come in.
Thank you. Yes, having been party to some of those earlier discussions that we've had, I think for everyone in the meeting, we started to talk about how you might explain in a lift to someone what the Health and Wellbeing Board did, what the Health and Care Board did, what the Neighbourhood Health and Care Board did, and what we were arriving at was that probably we thought that this board, the Health and Wellbeing Board, looked at strategy and the wider determinants of health. The City and Hackney Health and Care Board, so the place-based partnership that is part of the ICS and is our City and Hackney part of those 7 place-based partnerships that make up NEL, looked more at the delivery and the quality assurance of health and social care. And if there were specific things that legislation required your health and wellbeing board, us, to do, but that actually reference to delivery, we might think about perhaps we would delegate some of those functions to the City and Hackney Health and Care Board, because that's where we felt they sat better. And then to be very clear for senior leaders and delivery officers that their day-to-day service delivery and action planning of service delivery probably sat best at the Neighbourhood Health and Care Board. That would have been a very long lift ride, wouldn't it? I've just demonstrated that we're not there yet. But I hope that made sense.
A lift on a skyscraper. We're going very slowly. No, I think that's really helpful. It's really some clarity around roles and functions of each of the different groups. I think obviously recognising we are the Health and Wellbeing Board for Hackney, and we have City of London and our corporation colleagues working with us in our Health and Care Board and Neighbourhood Health and Care Board. So there's some slight complexities around that. But this was really to, putting it on the agenda today was really to just to sort of flag to the Health and Wellbeing Board that there are some discussions happening on how we can improve things in terms of roles and functions and clarity. And then we plan to build on these discussions over time. Baz, do you want to come in?
I actually think that analogy on the list was quite helpful in thinking about how we describe it. I suppose the other thing is around priorities in terms of where are priorities set. So we've got priorities that we kind of, each partner organisation sets its priorities. Sure, the Health and Wellbeing Board needs to set its priorities. We've got national priorities, and I suppose there's a conversation to be had about where do we set priorities and how do we make sure that they're aligned. And I don't have an answer, but that would be one of the things that would be good to have a discussion about, around who sets the priorities, and then how do we ensure that there's a single delivery plan that every person that works in City and Hackney can look at something that they have to deliver and be able to kind of map it like that to a City and Hackney priorities. Good to consider who sets priorities and where do we set those and how do we then drive it.
Sandra.
I don't think there's a simple, straightforward answer to that, but for me, it's about the relationship between the joint local health and wellbeing strategy and the ICB health strategy, and they should be informing each other, and we seem to be in that kind of fortunate position in City and Hackney where they're doing more of the informing, so actually at the moment it's quite handy. But we also always have to bear in mind that there'll be other national priorities that come up that aren't reflected in our strategies for all sorts of reasons, including just timing, and we just have to kind of roll with those. But if we bear in mind that we've got in fact we heard from Hilary earlier about the delivery plan for the NEL strategy, you could probably recognise loads of stuff in it, because it, in terms of the priorities, it really reflects our local priorities. And there is an intention, how well it's going to be realised, but there is an intention now to be delegating, what's the word? Delegation isn't quite the right word, but where things are best done at place, they should be done, and that there'll be things where, because there's an advantage for doing it across the whole of North East London, that they'll be doing it at that level, rather than us being told this should be your priority in City and Hackney. I hope that's helpful. And the point about the local health and wellbeing strategy is that it is going to be a joint strategy. And so the more we can make that, develop that as a collaborative piece, the more everyone will be able to recognise it.
Okay, any other questions, comments, feedback? Chris.
I mean, it's a reflection that Health and Wellbeing Boards have been the one constant in the last 10 years. So it's highly likely I think we're going to get a lot more change. And with the general election, change is almost the only constant that we're going to get. But I think the other thing the Health and Wellbeing Boards have been able to do is to bring that single focus onto a small range of subjects. So rather than, there's not going to be an absence of plans over the next 6 months to a year. We're probably going to get more and more requirements with plans. But I think the health and wellbeing strategy, by focusing on a small number of areas and actually learning the lessons of, because I think some of the times the national plans, you know, they almost are become a blank piece of paper rather than going, well, what worked last time? What do we want to do this time that's going to build on success? So I think the Health and Wellbeing Board's unique thing is being able to actually have that reflection back and about actually what's going to work for Hackney. Sometimes it is taking a national plan and running with it very strongly, and sometimes it's doing something in our own way, waiting for the national policy to catch up. I think that ability to learn lessons of what actually has worked and then ensure that continues, I think is important. The plethora of groups where it's often the same people, it's actually being able to be really clear what is your role in this group. And I think in the Health and Wellbeing Board, you know, there is a few statutory things. Integration is still a really important part of that. But I think it is the ability to have that constant look of, well, what works, what can we do this time, and how do we make the best of it.
Thanks, Chris. Tony.
Yeah, I just, yeah, thank you, Chris, actually, Councillor Kennedy, for that kind of description of how the different boards are distinguished, how they differ from each other. I think one of the things probably that was missing, how I don't know, it does link in this is safeguarding, because obviously wherever we get this wrong, that's where it then naturally falls to a safeguarding concern. So I think the other piece of the jigsaw puzzle is how do the Health and Wellbeing Board, how does the City and Hackney Health and Care Board, how does the Neighbourhood Health and Care Board link in with the relevant children safeguarding partnership? I forget City and Hackney Safeguarding Partnership and the Adult Safeguarding Board. How do they all link in together to make sure there's a full loop?
Yeah, very important point, and one that we need to think about over the coming weeks and months as we kind of progress the discussions. So thank you very much for the comments and feedback. These discussions will continue over the next couple of months, and then there is a plan to bring back a further discussion which will have some more tangible, concrete information behind it, and will then fall in line as well with a more detailed and updated terms of reference as part of that. But it is an evolving process and one that we need to keep talking about. Okay, we're coming towards the end and now moving on to any matters arising. Okay, no matters arising. So just to remind you all that the date of the next meeting is the 21st of September at 3 o'clock. And just really thank you very much for all the engagement, really interesting discussion around the substantive items we've had today. I'm really looking forward to seeing sexual health work coming back after the consultation. I'm really interested to see how all that goes. Thank you very much. Have a lovely evening when the evening arrives, and we will see you again soon.
It's doing something now that it wasn't doing before.
Thanks, Mariette.